Wanted to welcome everybody taking a little time at lunch here today. We wanted to talk a little bit about dry needling, the iliotibial band, IT band. Clinically, it's something we see all the time, regardless of our patient population. If there's a low back issue, if there is a posterior hip issue, we probably will find that there is. This is especially in our older population, some lateral thigh issues going on, some tenderness, some decreased strength, some lack of proper motion. We frequently find that to be an issue that needs to be resolved. Dry needling absolutely provides us a fantastic tool with which we can treat that. We'll talk also a little bit here about the symptoms that we see further distally around the knee, what we consider our runner's knee problems. So we'll take a look at the IT band both proximally and distally. One thing we'll look at, let me just come up to this slide right here. We'll take some time to talk about what the IT band syndrome is, specifically proximally and distally. Who it would be beneficial for, what diagnosis conditions we would expect to see, and how and why protocol was developed. We'll take a little look at some three-dimensional anatomy just to review what structures we want to be dry needling with this, and how to apply the dry needling protocol to those structures. We'll talk briefly about precautions with dry needling, then review again some relevant surface anatomy as we're going through the 3D piece. If you have any questions during this, feel free to enter those down in the Q&A section at the bottom of your screen. I'll try to address as many of these as time does allow. Again, feel free to throw something down there. If I don't get a chance, I'll try to address those questions after this little webinar. I will make this available for online viewing. I'll probably email the link to this out probably tomorrow for a lot of, if you didn't get a chance to watch it live, you will get an email with the link to this. So let's just dive right in. Patient conditions that would benefit from dry needling for the IT band syndrome protocol. Well, let's be honest, we're going to talk about two different areas here. The proximal iliotibial band or IT tract up around the lateral aspect of the hip, and then the distal aspect there that we see for our runner's knee, that IT band friction syndrome. And so we'll focus specifically on those two areas. So some problem areas or some focus of treatment. So a lot of times IT band is typically not just an isolated problem. If it is an avid runner, it definitely can have an aspect of the friction syndrome more proximally or distally, but more often than not, we're going to see a mechanical issue that's going on as well, whether it's a motion limitation, whether it's a strength issue. So there's usually something else that's going on. For a large majority of our population, a little bit older, we're going to see some other things as well. In there, we're going to see it associated with some sort of an issue, the lumbosacral junction. We also see with sacroiliitis, and all of these that I'm putting out here have to do with us making sure that we make a proper differential diagnosis of what the actual problem is. It doesn't mean that we won't treat the IT band as well, because it will be symptomatic, but we may have to look at other structures as well as we're trying to treat that. A lumbosacral pelvic junction, so a little bit lower, bringing in the pelvic rotator cuff as well as the low back and that lateral piece. Our traditional, in quotes, I'm using the word sciatica, that SI joint region. People with Piriformis syndrome. Again, all of these things we're going to see. A lot of this musculature does attach over to the greater trochanter, and because of location of the IT band running across the troch, headed down distally, we have to make sure that we're evaluating those as well. We can see it in conjunction with bursitis of the greater troch as well. Frequently, we'll see a misdiagnosis of the greater troch bursitis, that it can be one of these other issues as well, and not truly just a bursal issue. That's why we frequently see the cortisone injections just don't seem to knock that out. the ortho will hit that and hope that it'll knock it out. But we'll see that, lo and behold, there is some other stuff mechanically that's going on that we need to take care of. Traditional IT band syndrome, again, isolated in your more higher level athletes. It can be isolated just to that issue. More often than not, there's some other things going on, however. We can see some lateral knee pathology. So maybe there's an LCL sprain. Maybe there's some meniscal damage that's there as well. So we just have to make sure, again, looking at that differential diagnosis to make sure where the pain is coming from, what mechanically is going on, and make sure that we isolate that and treat all the relevant structures in the process. So lateral thigh pain is frequently prescribed and treated pain complaint. It's occasionally an isolated condition in certain demographics, but again, usually it's a secondary complaint to other issues that are going on. Clinically, we do see some very significant improvement in the pain symptoms of IT band syndrome through using dry needling as an adjunct to therapy. When I teach and when I talk to my patients clinically, dry needling is definitely not the only thing that we need to be doing here. There's a mechanical issue that's going on, but if we can use dry needling to resolve some of that first level, that pain complaint and that mechanical dysfunction, it'll probably let us get a little bit quicker to restoring normal motion, normal strength, and mechanical function of the extremity. Again, primary goal here is to reduce muscular tension to decrease radiating pain symptoms. In IT band specifically, we are treating a little bit more of the soft, of the connective tissue as well. We will deal with some muscular issues as well, but we're also looking for that healing response through dry needling of the connective tissue, the ligaments, the tendons in certain situations, the bursa. So we're definitely still looking at the primary goal, reducing muscular tension on that TFL down through the iliotibial tract, but it is the other associated structures as well that we want to make sure we're looking at. So with dry needling, there are some instances where we'll use tissue mobilization to release impinged nerves, which can be a direct cause of lateral thigh pain. We will talk about a perineal a nerve treatment for lateral femoral cutaneous nerve that could be associated with this condition. And we frequently use manual therapies to make an impact on the patient's pain presentation. As a neuromuscular approach, we can have that same impact by utilizing dry needling to create that same outcome. My experience is a lot of times we can get an even stronger impact through using the dry needling through those tissues, and then supplement that on a subsequent or after dry needling subsequent visits with that manual therapy, whichever approach you choose to use with your patient population. I've reviewed many research studies that claim varying results with the use of dry needling for IT band syndrome. In some cases, the authors will describe the actual dry needling protocol by needle placement, and some will not. I developed these protocols and the specific needle placements for the IT band syndrome, as well as numerous others, based on the location of the symptom complaint, the area of tissue inflammation, and the target tissue of symptom provocation. So with the IT band friction syndrome, both the proximal and the distal, quite a few different structures that could potentially be dry needle depending on the presentation and on the symptoms being demonstrated. Most definitely the tensor fascia lata, and we'll look at the anatomy here in a moment, which is the tensor piece to the iliotibial tract, again, both proximally and distally. Because of its location, the vastus lateralis can frequently be a player in these symptoms, most definitely because of their attachment to the greater trochanter and the TFL itself, the gluteus maximus, the medius, and minimus. Frequent complaints similar of the trochanteric bursa of both gluteus maximus and medius. Piriformis, again, because of its trochanteric attachment, can be an issue that needs to be addressed as well, just for, again, demonstrating good differential diagnosis. We move further distally down to the lateral aspect of the knee. We'll have to evaluate and possibly dry needle the lateral patelloretinaculum, the lateral patellofemoral ligament. To a little bit further posterior, we have to evaluate, is the biceps femoris, is that tendon creating some issue for us as well? The lateral collateral ligaments, further high on the hip, kind of out of order there, iliofemoral ligament could be an issue as well. And then the nerve component, the lateral femoral cutaneous nerve, there could be some entrapment there, creating compounding effect with that pain presentation. And then further distally, there is the iliotibial tract bursa, which sits below the iliotibial tract at the lateral femoral condyle. So just some general dry needling precautions. There's some that are joining the webinar today that are veterans of dry needling, and this is something that you've researched, studied, and are aware of for many years. Some folks are joining who've never picked up a needle before. So I just want to briefly touch just the general precautions that we look at. So contraindications, most definitely if there's non-consent from the patient. If we don't have buy-in from the patient on dry needling, then outcomes tend to not be that well. So definitely have to get that verbal and preferably written consent to treatment. Medical legal reasons for the first trimester of pregnancy. We have no business dry needling nipples, umbilicus, external genitalia. If there's out of control anticoagulant usage, we want to stay away from that until that is brought under control. Obviously means there's some other medical issues going on. If there's a local infection in the area, there's no reason for us to needle into there. If there's an active tumor of any type, also don't want to get involved with that. If someone has a Chiari malformation in the occiput, we definitely don't want to needle into that area simply because we don't know exactly what the structures are, what's going on, and there's no reason to compound that problem. If there's implanted electronics, pacemaker, defibrillator, any of the newer electronics that are used for different reasons, I definitely want to stay away from that. You can needle around it if necessary, but definitely not a bad idea to talk to the surgeon who did the implant themselves just to get clearance for that. And then into a person with some post-surgical lymphedema in the extremity, definitely stay away from that. Some relative contraindications post-surgically, 6 weeks with any communicating tissue, 12 weeks in a local surgical area. I have needled very, very commonly to needle earlier than that, but I definitely don't do it without the surgeon's consent. So as long, depending on your relationship with the surgeon, you may find that you can do that a little bit differently, but just to try to minimize infection, that's a good idea there. And then autoimmune disease or history of lymph node removal and certain respiratory illnesses. Precautions, a person that may be have an aversion or a phobia to needles itself. If there's a significant cognitive impairment, move further down. Most definitely the biggest thing we get concerned about is pneumothorax. So any dry needling in and around the rib cage, we definitely want to definitely follow our rules, our guidelines for dry needling to make sure that we don't pierce into the lung tissue itself. Additional precautions, areas of breast implant in the spine, laminectomy, scoliosis, and severe osteoporosis. Any of those things can change the layout of our backdrops, of our surface, of our deeper anatomy where we're going. So just definitely have to be cognizant of what's going on there. For the perineural dry needling, it is becoming more prevalent. I know clinically I use it fairly extensively when I'm dealing with a complex case. It's a little bit less common to have just an isolated neural impingement, except in the case of like carpal cubital, in the case of the posterior of the occiput for headaches and so forth. But there are quite a few other issues that we can deal with. Lateral thigh can also have some entrapment syndrome. Again, lateral femoral cutaneous nerve can become entrapped and reproduce some of those symptoms laterally. I like to use the perineural dry needling, hopefully in place of traditional nerve blocks. So if we can get in there and we can mobilize that tissue, free up that nerve, stimulate the neural response, then I think that's a fantastic approach and less invasive. Peripheral mechanism centered around decreasing the localized inflammation in tissues that's causing the impingement. There's also a central desensitization that occurs, and interruption of the sensory afferents and nociceptors that are signaling the pain response. There's a sparsity of evidence concerning the mechanisms of perineural dry needling. Definitely more needs to be done in that regard. Anecdotally, however, we are seeing some pretty good results. So let's take a quick, I'm going to share my screen, and let's take a quick look at some anatomy of what we're dealing with here. So all of the 3D anatomy that I use with permission of a complete anatomy. There's a lot of different programs out there. This is the one that I use. I've used a lot of different ones, but I really like the context and the content of complete anatomy. I think it's critical in dry needling that we use a 3D anatomy application just so that we can have a good understanding of where the tissues are and where we're dealing in relation to the body. So what I want to look at briefly, we'll just talk about the iliotibial tract, or the IT band itself. The band comes off of the iliac crest. On the anterior aspect, here we do see the TFL, the tensor fascia lata, which provides the contractile element of this tissue. Interestingly, on the posterior aspect, its counterpart is the gluteus maximus. So together they form a nice tensioning of this IT band. And so we'll talk in just a moment about making sure that we have to include the gluteals, the pelvic rotator cuff in the treatment approach whenever we're dealing with the IT band. Otherwise, we're missing a key issue of what can be causing some of that neuromuscular tension throughout this tissue. So we move further down, again, underneath, and I'm going to hide this. I'm going to fade that a little bit. Let me fade TFL and glute max. So a lot of times we'll see, you can see the greater trochanter. It's kind of hard to see. The greater trochanter right here underneath the IT band. And that's where a lot of our proximal issues are centered. But you can tell we've got glute med, glute min, piriformis. There's a lot of other structures that are attaching and coming around here that can create some issues. It's harder to see, but there's the greater troch bursa here of medius sits up a little bit higher. But that's the proximal structures. We move further distally, and let me bring this back into view. So as the IT band comes down, one thing it does is it's going to pierce between the heads of the lateral patellar retinaculum. And it's headed on its way to the lateral superior aspect of the tibial plateau. So I'm going to hide that. So where we tend to see our friction, our problems, is right around the lateral femoral condyle. As it comes across the lateral patellofemoral ligament, between that and the IT band, you can see we have iliotibial tract bursa. So obviously that's there to prevent, reduce any friction. So whenever we are looking at our dry needling, these are the structures that we are concerned about, where that's coming down. And again, this lateral issue, this friction syndrome with our runners especially, that's where we tend to see our problems. But along the way, we do know, because of its location with vastus lateralis, that can at times be an issue. If symptoms are diffuse, we may be looking at the lateral collateral ligament there, or we could be talking about the biceps femoris tendon itself. So all structures that may be involved with what we're dealing with. And again, good differential diagnosis will get us where we need to be there. So let's move on to, let's see here, some treatment. So starting with the muscles itself, and I will go through, I've recorded a treatment session yesterday because I knew I'd have a patient available that I could do that. So we'll look at that in a moment. But just want to talk a little bit about the treatment locations, a little bit about my approach to dry needling. I am not a trigger point clinician. I enjoy whenever we get a good twitch response out of dry needling, but that's not my ultimate goal. My goal is to reduce that neuromuscular tension. There's research out that says we don't have to have that twitch response in order to elicit those same responses. And my approach, I seem to see more tolerance throughout patients without multiple pistoning efforts to elicit that response. I'm also not looking for specific acupoints. There are some that rely heavily on that. That's not my objective. I want to look at specific landmarks to identify consistent, specific needling locations. So for the tensor fasciolata, we're going to needle. So a lot of these diagrams I've got will demonstrate needling in prone. And when I teach doing this either in prone or in supine. Clinically, I'm going to do this in the sideline position because it's just more efficient to do it that way. So we want to hit the TFL, and here I'm just looking for a midpoint between greater troch and the iliac crest, and I'm going to needle either lateral, posterior to anterior, or anterior to posterior, depending on the patient's position. We'll use my fingers for a backdrop to make sure that we don't roll through. So here it is in the prone position. Again, I'm just going to needle from that posterior aspect through the IT band itself and then through the fibers of the TFL. We move on to vastus lateralis. My approach, I'm going to take a midpoint in the femur or in the upper thigh, and I'm going to come just a finger breadth maybe above the IT band. It's definitely palpable. That will give me a good response right into that vastus lateralis. The vastus lateralis is not always indicated in this, but if it is, this is a good landmark to drop needle. It's just going lateral to medial towards the femur to treat that muscle. Again, right here we see the line indicating the IT band, and I'm just going to come interior just slightly to pierce into vastus lateralis. For glute max, I'm going to locate the greater trochanter and the PSIS, and I'm going to draw a line between the two, and at a midpoint, I'm going to be able to use that as my reference. I'm going to drop needle through glute max. I'll actually drop through glute max, glute med, and I may catch some posterior fibers of glute min. This is what I call a magic spot. Most things with the glutes, the posterior hip, we can catch a lot of the tissue in this one single needle spot. But for this purposes, I use this to identify glute max. Again, the backdrop is the ilium, and needle will just be perpendicular to that. So here you see that represented PSIS greater troch with a midline and using the ilium as the backdrop. For glute med, I'm going to follow the IT band up to the iliac crest, and that's palpable. You can feel it as it comes to that location. I'm going to move back posteriorly 3 finger breadths and then drop down another 2 to 3 to drop into the specific fibers of glute med. Again, the ilium is the backdrop for that, and that will look like that there. So I will have dropped glute max here. I'll come up over 3, down 2 to 3 for glute med. For glute min, I'm going to use a very similar needle location that I did for TFL. Here, what I'm going to do is, again, greater troch to iliac crest. Instead of going posterior to anterior, anterior to posterior, here I'm going to go lateral to medial to land in the center of the fibers of gluteus minimus. It's fairly deep, so a little bit deeper or longer needle, so I make sure I get good depth into the fibers of gluteus minimus. And so that will actually look just like that. And then piriformis. Again, we're using greater troch as our reference point. We're going to move up a finger breadth, and then we move over 2, 2.5, maybe 3 finger breadths more towards midline. Choose this area so that we can stay away from the course of the sciatic nerve that's going to come right here as my mouse is moving across that location. It can be needled off the lateral sacral border. I find clinically that that's not always relevant. Our best response seems to be out for more and more laterally. And again, it provides some safety away from the sciatic nerve itself. And that looks like that. If we are down further distally and we're thinking there may be maybe it's not a true IT band issue, we need to bring the biceps femoris into play and get some reduction in muscle tension there. Then I will just take one palm breadth above the popliteal crease, and I'll move one thumb breadth lateral and needle away from midline to get a good response there. Here I can catch both the long head and the short head with the proper length of needle into that short head. And that will look exactly like that. So we also have some other issues or some areas that we want to look at. Yes, we do frequently deal with some true trochanteric bursitis. Difficult to differentiate that from true IT band problems. So while we're there, we may as well go ahead and treat that. Ideally, we'll palpate over the greater troch, the apex, and see if there is any true issue there. And very easy just to needle down onto the apex of the greater troch and to hit onto that bursa. We look a little bit more superior, we see that there's another bursa of gluteus medius. More often than not, I suspect these are one contiguous bursa. For the purposes of this 3D anatomy, it does show it to be separate. So never a bad idea. Frequently, I'll just move a couple finger breadths up and I'll needle a little bit deeper to make sure that I catch the entirety of that. I do see that we get some good response from bursitis issues through dry needling, just stimulating some healing response in that tissue does seem to provide some good response. We can also drop a little bit further into the iliopectinial bursa. It's a little bit more anterior, but we're going to deal with the wide ligament as well. And so this is done a little bit more in the supine position, moving a little bit away from the femoral artery. We can drop deep onto that tissue and get a good response there. That would almost easily be identifiable as a more of an anterior problem. But if you resolve some of the lateral, more true lateral aspect condition, and you still are dealing with a little bit more anterior, you may want to look at that issue as well, because there may be a movement issue, maybe iliopsoas is a little bit tight, and we need to come in there. A lot of times we can hit iliopsoas at the same time as we're hitting this bursa. So the iliopectinial bursa is also something to include in the toolbox of tissues that can be treated. Again, similar to the iliofemoral ligament, it could be with some tightness, with some restriction, needling down onto that would be a way to go. Again, we can identify a bend point between ASIS and apex of the greater troch, and then just drop down onto that ligament as well. A little rotation of the needle should elicit some response with that. So we move further distally down. So a lot of tissue up around the upper aspect between the upper, the hip itself, the greater troch, and down towards its distal attachment. We absolutely can place needles along, shorter needles along the IT band, the iliotibial tract, all the way down. We might see that we can elicit some change there. More often than not, if we deal with a problem proximally or distally, those issues in between those areas will resolve themselves, especially if we throw some appropriate some manual therapy, some flexibility work, some range of motion, some strengthening. That should take care of itself. But if there's a residual issue, you can definitely drop 1, 2, 3, 4, 5, as many needles as you want down that tendon itself. But we do move further distally. We talked about IT band coming and piercing or bisecting the lateral patellar retinaculum as it travels to attach on the Gerdy's tubercle. So there are times where, let's see if I've got that there. Yes. So we can take just lateral to the patella itself, and we can drop the needle into the lateral patellar retinaculum. We can actually just split a little bit on either side of the IT band itself and drop needle on either side to make sure that we address all the fibers of the lateral patellar retinaculum. Similar with the lateral patellofemoral ligament, we can drop just a finger breadth off of the midpoint of the lateral border of the patella and drop into there. Interestingly, if we're going to needle the lateral patellar retinaculum, as we drop this most medial needle, we're going to drop down into that the ligament anyway. So drop that needle just a little bit deeper, drop it down onto lateral femoral condyle, and we'll cover two structures at the same time. And then we actually talk about hitting the iliotibial tract itself. And so as you notice, everything is in a midline across the patella, the lateral patellar border. If we identify that IT band as we're palpating laterally, then we can really drop needle 1, needle 2, needle 3, and address all 1, 2, 3 structures with those 3 needles and get a really nice response. If we do find that our symptoms are more distal at the actual attachment, then we can come down onto the tibia itself, and about a finger breadth or half a finger breadth lateral from the patellar ligament at its attachment, we can drop a needle there as well to get a response out of that tissue. More often than not, the pain and symptoms are here at the lateral femoral, the lateral femoral condyle on the femur, and we can drop those 3 across right there and get it, take care of those symptoms right there. May find that, again, we need to deal with the lateral collateral ligament. We just, again, palpate as we do, locate that and just drop it right in joint line to impact that. And again, here we want to make sure that we differentiate runner's knee, which is, we'll consider 2 types, just normal patellofemoral syndrome pain versus the IT band friction syndrome. Here we're more talking about that IT band for the runner's knee. Patellofemoral, if we don't address the patellofemoral retinaculum and the patellofemoral ligaments on the medial aspect, then we're not going to be addressing everything for the patellofemoral syndrome. But here on the lateral aspect, those 3 needles right there will take care of a lot of that distal issue. I do not know why I threw the greater troch bursitis slide in. We talked about that. For the greater troch bursitis, I do look at a lot of different things. It's a piece of the IT band friction syndrome, and they are very similar in their approach. So I will needle both of the bursa. I'm going to come up. I'm also going to needle into TFL and IT band, but I'm going to make sure that I include a glute max med, piriformis, and the deep hip rotators itself. And then for the IT band, again, a very, very similar approach. One difference, and I don't have it demonstrated down here, for the IT band syndrome, I may hit all of these structures, but I may also drop all the way down and place some needles through the IT band itself. And if there is presence of some distal symptoms at its attachment, then I may go ahead and needle into those 3 lateral structures as well to make sure that we're getting a good response out of that. We look a little bit further. Okay, I did talk about, let me play a little bit of. All right, so dry needling for the IT band. We're going to talk about 2 different pieces. Obviously, we have the proximal IT band around the hip. Here we're thinking of things like greater trochanteric bursitis and a number of other issues that we've talked about. But then we can also talk about that distal IT band friction syndrome, the runner's knee complication that we get. But let's start up higher. A lot of people do get really nervous and apprehensive about needling for the IT band. And honestly, it's one of the easiest things that we do. We want to think about the different musculature that's attached onto the greater trochanter. So obviously palpation, incredibly important. The obvious direct connection, TFL, tensor fascia lata, attaching to the iliotibial tract as it's coming over the greater troch and then coursing down distally. At the knee, it's going to split between the lateral patellofemoral, lateral patellar retinaculum, sitting right on top of the lateral patellofemoral ligament, and sitting between that is the iliotibial tract bursa. And right there at the femoral condyle is typically the place where we see that inflammation. So a few places that we want to needle here. First off, we want to deal with TFL. I prefer doing this at sideline. We're just going to grasp it. It can be from posterior to anterior, anterior to posterior. Sits fairly superficial off the iliac crest, roughly in this area right here. We can also, that direction, we can also go straight lateral to medial. And the reason we might do it this direction is directly underneath, we're going to be dealing with glute min. Glute min is also going to attach to the greater troch. We would also drop a little bit posteriorly into glute med as well, also having the attachment. There will be another spot midway between greater troch and PSIS that is a great spot to hit gluteus maximus. So let's hit those spots. As I'm doing for TFL, I'll also needle a little bit superiorly to get the trochanteric bursa in that area. But my general approach, we're going to split the difference for TFL, going to drop straight in and all the way down for TFL and glute min. We'll move a little bit more posteriorly. We can follow the IT band up, iliac crest, over and down for glute med. Drop towards ilium there. And lastly, on a more superior aspect, we can deal with the glute max spot, which will be right here. I frequently will also hit piriformis. Piriformis will sit a couple fingers up, a couple fingers posteriorly, right about there. Because it's attachment onto the greater troch, it can also be a significant issue at times. As we move further down, we can also talk about anywhere along the path of the IT band that can be needled if there's some issue there. The vastus lateralis sits directly beneath the IT band, so we may pierce into that as well. Nothing wrong with that. It also has a function. But down further distally, as we look for the IT band, as it crosses the lateral femoral condyle, we'll know the point of friction is right there. It's traveling to its insertion point just lateral to the patellar ligament at the superior aspect of the tibia. But more than often than not, the tender spot is right here, very superficial. Take the feather out. So palpate again, joint line just superior to it into both iliotibial tract bursa and into the iliotibial tract itself. So here we're catching the entire length of the IT band from its origin at the iliac crest all the way to its tibial attachment further distally. Again, most important thing here, it's rare for the IT band to be an isolated injury. Usually there's some other comorbidity going on as well, either through the muscles of the hip, the rotators, or some other function. So you want to be careful to identify your cause of the issue. Okay, so let's move on. I'm not gonna demonstrate this, but on the perineural for the lateral femoral cutaneous nerve, obviously it's got a lateral sensory distribution. And as we look at the anatomy there, it's going to come out just a little anterior to the sartorius as it comes down. Then it's going to take a course really along the bifurcation of, or the valley, if you will, between the VMO and the rec fem as it's coursing right there. And so a lot of times we can just hit that up high right as it's coming out beneath the inguinal ligament right there, and then take 3 or 4 spots on down the course of that nerve as well. And again, just kind of demonstrating the locations there. So a little bit of conversation about dosage and frequency. How do you determine that? I tend to divide all of this up into about 5 different categories. Move on to that. So athlete, 2 stages of an athlete. One person with no comorbidities, issues brand new within the first 10 days of injury. Here, there's not been a change in strength or performance level. Here, we're probably just going to have to dry needle 1 to 3 times in the first 3 to 5 days. Here, prognosis is excellent. Should be able to resume normal training within 2 to 4 days. So there's been a quick sudden onset of a small little strain. Something has changed, but mechanically nothing has happened yet. Those should respond extremely rapidly The other situation is when there's one or more comorbidities, and this situation is moved to a subacute stage 14 days plus. Here they have had some asymmetries in their strength and performance. This may require a little bit longer time. Here we may be looking at 3 to 6 sessions within the first 1 to 3 weeks. The prognosis still is excellent, but it may take 2 to 3 weeks of training to restore their asymmetries, and then they can resume their normal performance or high-level training. For the average Joe, our weekend warrior, they're in decent physical shape. They've had some sort of incident that resulted in a strain or an overuse injury. Again, we're going to dry needle 1 to 3 times within the first 3 to 5 days. Their prognosis is excellent, but they will need to adapt an ongoing HEP to address the mechanical deficit that set them up for the injury in the first place. So out doing some things, got a little aggressive, did more than they thought they could. They can get back to normal as long as they address the mechanical problem that was there to begin with. The quick stick, this is our work colleague, our family member, the person who just slept wrong, who has a little ache over here, needs a quick fix. We're going to needle them 1 time. Their prognosis, however, is just fair. The problem is there's some underlying issue that's going on, and we're just putting a Band-Aid on it. It's not the best way to approach healthcare or dry needling. However, we all have found ourselves in that situation where the upper traps hurt, or we worked out a little bit too hard, the quads are very sore. These folks, again, just fair because there's an underlying issue. They will need some sort of a home exercise program to correct the mechanical issue, but odds are they won't be willing to accept that or be willing to do the work. There's a decent chance that this person will become what I call the procrastinator. The procrastinator, they're going to have 1 to 3 comorbidities. They've been dealing with this pain and function complaint for months, if not several years, and they're unable or unwilling to deal with the issue due to a variety of either valid reasons or just excuses. And now they've got motivated, they've decided to do something about it. Here, this is going to take a good 8 to 12 sessions within the first 30 days. They're going to take a full plan of care to take care of this situation. Their prognosis is good, however, their success will depend on their compliance with their home exercise program. They have to do their part on the backside. Again, dry needling is a fantastic modality, but it is simply that. It's just a modality. If we don't change and make the right corrections to the mechanical deficits that set that issue up in the first place, then we're still dealing with the same problem. Then lastly is the hard case. Here there are multiple comorbidities. There's severe OA or DJD. There are other issues that really require surgical intervention, but say maybe they've got some pulmonary or some cardiac complications that they just can't have that clearance. Here, the frequency, dry needling is 8 to 12 sessions for the first 30 days. There may be another 4 to 8 for the second 30 days and 2 to 4 sessions for the third 30 days and beyond. And so we're going to be honest on what this is. This is long-term maintenance. Their prognosis is fair. We're not going to be fixing these people. We're going to be maintaining their pain levels. This is basically non-pharmacological pain management. Insurance may be an issue here that may require some sort of a cash pay situation. There's limited improvement because of the nature of their debility. However, if we can make that difference and keep their pain minimal and let them maintain a higher level quality of life, my opinion, that's a better choice than being on pharmacological agents to manage that. I think we do a much better job in handling that. So if there are Q&A, that's basically what I wanted to talk about. There's the IT band, whether proximally or distally, is a really quick, really easy place to treat, to get some good response to pain, to reinvigorate and get some movement in there. But I'm going to yell really quickly at my moderator to see if there are any questions that I needed to deal with. I can tell you that I will wrap this up momentarily. I will get this out to everybody that signed up for it and over to you. While we're looking at that, the next thing that we're going to be doing is on September the 15th, I'm going to demonstrate the subdeltoid subacromial bursitis, or let's just call it what it is, shoulder impingement. We dry needle shoulder impingement very frequently. and see really great results with dry needling in that regard. Again, it's just a tool. We have to do the work, our manual therapy. The rest of it has to go on. But as far as knocking that high-level pains and let us, get past that and get down to business, protocol for impingement is very, very good. So if you have any questions, feel free to reach out to me. You got my contact information there. And if not, you will get this recorded and out to you guys probably tomorrow, and look forward to talking in a month about shoulder impingement.